I want to start today with a number that genuinely stopped me in my tracks when I first came across it in the research literature. Heart disease kills more women every single year than all cancers combined. Every single year. And yet, when I ask women in their 60s, women who are intelligent, well-read, switched-on women, what they think is their biggest health risk, the vast majority of them say breast cancer. I understand why. The messaging around breast cancer has been extraordinary. Decades of awareness campaigns, of pink ribbons, of fundraising walks. And all of that has saved lives. I am not dismissing that for a single second. But somewhere along the way, the conversation about women's hearts just got lost. And that gap in awareness, that silence, is costing women their lives. So today, we are going to change that. For you, right now. My name is Margaret Claire. I spent 22 years at the University of Edinburgh studying how women's bodies age, and specifically what happens to our cardiovascular system in the years after menopause. I am not a doctor. I will never claim to be. But I am a scientist who has spent over 2 decades reading the data, sitting in the research conferences, and watching the evidence accumulate. And what that evidence tells us about women's hearts after menopause is something every woman watching this needs to hear. Let me set the scene for you. Before menopause, women are remarkably protected from heart disease compared to men. Our risk is substantially lower, and for a long time, researchers assumed this was just biological luck, some inherent female advantage. But it is not luck at all. It is estrogen. Estrogen is doing something extraordinary inside your cardiovascular system your entire adult life, and most women have absolutely no idea. When estrogen levels begin to fall, first fluctuating wildly in perimenopause, then declining sharply through menopause, that protection begins to dissolve. And the speed at which heart disease risk climbs in the decade after menopause is something that, frankly, should be front-page news. Within about 10 years of menopause, a woman's cardiovascular risk essentially equals that of a man of the same age. And by the time we reach our 70s, our risk actually surpasses men's. Let that sit with you for a moment. We go from being more protected than men to being more vulnerable. And the transition happens right in this window of life, this post-menopausal decade, when most of us are not even thinking about our hearts. So let's talk about what estrogen was actually doing in there. Because understanding the mechanism is how you understand the urgency. Your arteries are not rigid pipes, or at least they should not be. Healthy arteries are elastic. They expand when blood pulses through them, and they contract again. They breathe, in a sense. Estrogen is one of the key regulators of that elasticity. It works through receptors embedded in the walls of your blood vessels. And yes, we have estrogen receptors in our artery walls, in our heart muscle, in our brain, in our bones, essentially throughout the entire body. When estrogen binds to those receptors in the arterial walls, it maintains something called vascular compliance, the ability of the vessel to flex. When estrogen drops, that compliance begins to decline. The arteries gradually stiffen. They become more rigid. And rigid arteries cannot regulate blood pressure the way they should. So what do we see? Blood pressure creeping upward, often slowly, often silently. A woman who has had perfectly normal blood pressure her entire life starts to see it ticking up in her early to mid-50s and assumes it is stress, or rushing around, or just a slightly off reading. And sometimes her doctor agrees with that interpretation, because nobody in the room is connecting the dots back to menopause. And it is not just blood pressure. Estrogen also has a direct effect on your lipid profile. Before menopause, estrogen helps keep LDL, what most people call the bad cholesterol, at lower levels, and supports higher HDL. When estrogen falls, LDL rises, often by 15 to 20%. Triglycerides can increase. The lipid balance that estrogen was quietly maintaining for decades suddenly shifts. Again, silently. No symptoms, no alarm bells, just numbers changing on a blood test, if anyone is even ordering that blood test. And then there is the inflammatory piece. Estrogen has anti-inflammatory properties. It modulates the immune response in ways that protect the cardiovascular system. As estrogen declines, low-grade systemic inflammation tends to increase, and chronic inflammation is one of the key drivers of atherosclerosis, the process where plaques build up inside the artery walls. These fatty deposits narrow the channel through which blood flows. Over time, if those plaques rupture, a clot can form and block the artery entirely. That is what we call a heart attack. Now here is something I need you to understand, because this changes everything about what you think you know about heart attacks. The way that heart disease typically develops in women is genuinely different from the classic pattern in men. And for decades, cardiology essentially ignored this distinction. When most people picture a heart attack, they picture the dramatic, sudden event, crushing chest pain, radiating down the left arm, gasping for breath, collapsing. That presentation is real, but it is predominantly the male pattern. Women's heart attacks often look completely different, and because cardiology built its entire diagnostic framework around the male presentation, women have been, and in many places still are, sent home from emergency rooms while they are actively having a heart attack. What does a heart attack look like in a woman? It might be profound, inexplicable fatigue that has been dragging on for days. It might be nausea, a vague feeling of being unwell that comes and goes. It might be jaw pain or shoulder ache. It might feel like indigestion that will not resolve. It might be a sense of breathlessness that seems out of proportion to any exertion. These symptoms are subtle enough that women often explain them away. I am just tired. I must have eaten something. I am coming down with something. And sometimes, if a woman does go to the doctor or to a hospital with these symptoms, they are attributed to anxiety, to stress, to panic, not to her heart. Part of the reason women present differently is that the pattern of disease in our arteries is often different. Men tend to develop large, concentrated blockages in the major coronary arteries, the kind that cause a sudden, dramatic cutoff of blood supply to the heart. Women more often develop a diffuse, studded pattern of smaller plaques distributed throughout the coronary vessels. Blood can still get through, but it is struggling, and so the symptoms are more vague, more intermittent, harder to pin down. Additionally, women are more prone to something called microvascular disease, problems in the smallest blood vessels feeding the heart, which is even harder to detect on standard cardiac tests. This matters because it means that a woman can have significant cardiovascular disease and a perfectly normal-looking stress test. She can go through the standard cardiac workup and come back with apparently normal results, when actually there is real damage occurring at a level the testing is not designed to detect. I am telling you this not to frighten you. I am telling you because knowledge is protective. When you understand what you are dealing with, you can advocate for yourself. You can push back. You can ask better questions. So let us talk about symptoms. Not just the obvious ones, but the ones that your body might already be whispering to you. Hot flashes are not just an inconvenience. Research presented at a major cardiology conference in recent years found a direct relationship between the frequency of hot flashes and the narrowing of the carotid arteries, the large vessels in your neck that supply blood to the brain. Women experiencing more frequent hot flashes showed greater arterial narrowing than those with fewer. What does that mean? It means hot flashes are a cardiovascular signal. Your body is telling you that your estrogen fluctuations are having real effects on your vasculature. A hot flash is not just an embarrassing inconvenience. In a very real sense, it is your cardiovascular system asking for attention. Sleep disruption is another signal that is far more serious than most women realize. Research has established that chronic sleep deprivation, specifically fewer than 5 consecutive hours of sleep, is an independent risk factor for heart disease. And what happens to sleep after menopause? Night sweats, racing thoughts, lighter sleep architecture, more frequent waking. Many postmenopausal women are accumulating sleep debt without realizing the cardiovascular cost. And then there are the subtler signs: joints that stiffen, skin that becomes drier, mood changes, brain fog, energy that flags by mid-afternoon. These are not just quality of life issues. They are systemic signals of estrogen withdrawal affecting multiple body systems simultaneously. The cardiovascular system is one of those systems, and arguably the one where the stakes are highest. Now let us talk about what you can actually do, because I am not here to deliver bad news and leave you there. I want to give you a practical framework for protecting your heart in this stage of life. The first and most important thing I want to say is this: get your numbers checked, all of them: blood pressure, fasting lipids, LDL, HDL, triglycerides, blood sugar and HbA1c, inflammatory markers like C-reactive protein, and ask for something called Lp(a), lipoprotein(a), which is a genetic type of cholesterol that significantly elevates cardiovascular risk and is almost never routinely checked, despite the fact that elevated levels are quite common, particularly in women of African and South Asian descent. Lp(a) does not respond to statins the way LDL does, so knowing your level shapes the entire approach to risk management. Most women have never been told to check it. Start asking for it. If your LDL is elevated, and remember, postmenopausal estrogen decline often drives a 15 to 20% rise in LDL, have a serious conversation with your doctor about whether medication is appropriate. Statins, when used correctly, can substantially reduce cardiovascular risk. There is a common perception that statins are primarily a medication for men. The data does not support that perception. Women are consistently underprescribed cholesterol-lowering therapy relative to their cardiovascular risk. If elevated lipids run in your family, or if your own numbers are climbing, this conversation needs to happen. Have your blood pressure measured properly, not just once in a rushed appointment. Sit quietly for 5 minutes before the reading. Have it checked at different times of day. If it is consistently above 130/80, take that seriously. The silent nature of hypertension is what makes it so dangerous. You can feel perfectly fine with a blood pressure that is quietly damaging your arteries every single day. Now, hormone therapy. I know this is a topic that many of you approach with apprehension. The research of the early 2000s frightened millions of women away from hormone therapy, and that fear has lingered. But the scientific picture has evolved enormously since then, and I want to share what the current evidence actually shows. The timing matters enormously. Women who begin hormone therapy within 10 years of menopause or before the age of 60 appear to derive a meaningful cardiovascular benefit. Research looking back at the data from large trials found that in this group, women who started estrogen relatively close to menopause, there was evidence of reduced cardiovascular risk and slower progression of arterial plaque. Estrogen, in the window when arterial walls still have healthy, responsive receptors, appears to have a genuinely protective effect. Once plaques have calcified significantly, once the arterial damage is more established, estrogen does not appear to reverse that. And in women more than 10 years past menopause who have never used hormone therapy, starting estrogen therapy does come with a small increased cardiovascular risk in the first few months of use, before the body adapts. So timing genuinely matters. What this means practically, if you are in the first 10 years after menopause and you have been considering hormone therapy for your symptoms, the cardiovascular evidence increasingly supports having that conversation with a knowledgeable clinician. Not primarily because of the relief from hot flashes and night sweats, though that is real and meaningful, but because of the potential long-term protection for your heart, your arteries, and your brain. The forms of estrogen matter too. The research that generated the most concern was based on oral estrogen, pills taken by mouth, which is metabolized differently than transdermal estrogen delivered through patches, gels, or sprays. Transdermal delivery appears to carry a more favorable cardiovascular and clotting profile. This is an important detail to discuss with whoever is managing your care. Now let us talk about lifestyle, because no conversation about cardiovascular protection is complete without it. And I say this with genuine respect for how demanding your life is. I am not here to hand you a list of instructions as if you have not already tried your best. But movement is non-negotiable when it comes to cardiovascular health. The human body was built to move. Our entire cardiovascular system, the heart, the arteries, the capillaries, is conditioned and maintained by regular physical activity. For postmenopausal women, the most protective form of exercise combines two things: cardiovascular work and resistance training. Cardiovascular exercise, walking briskly, cycling, swimming, dancing, whatever you actually enjoy and will sustain, trains the heart, improves arterial elasticity, lowers blood pressure, improves cholesterol ratios, and reduces inflammation. Aim for at least 150 minutes per week of moderate intensity activity. That is 30 minutes a day, 5 days a week. And if you have not been active for a while, start with 10 minutes and build from there. Any movement is better than none. Resistance training, weights, resistance bands, body weight exercises, matters for your heart as well, not just for your muscles and bones. It improves insulin sensitivity, helps manage blood sugar, and over time contributes to a lower resting blood pressure. 2 to 3 sessions per week is the target. If you are new to resistance training, start with guidance from a qualified trainer who has experience with older women. Nutrition. After menopause, the way your body processes food changes. The drop in estrogen affects insulin sensitivity, fat distribution, and inflammation. The dietary approach that protects your heart most effectively is one centered on vegetables, legumes, whole grains, oily fish rich in omega-3 fatty acids, and olive oil as your primary fat source. Limit refined carbohydrates and ultra-processed foods. Reduce sodium, not by becoming obsessive, but by cooking more of your own food and reading labels with awareness. Alcohol, if you drink it, should be genuinely modest, ideally no more than a small glass a few times a week, and if you can reduce further, your cardiovascular system will benefit. Sleep. I said this earlier, but I want to say it again directly. Poor sleep is not just making you tired. It is raising your cortisol, increasing systemic inflammation, disrupting blood pressure regulation, and altering glucose metabolism. Protecting your sleep is a cardiovascular priority. Create a consistent bedtime, limit screens in the hour before sleep, keep your bedroom cool and dark, and if night sweats are disrupting your sleep significantly, address that with your doctor, because treating the underlying hormonal disruption is part of protecting your cardiovascular health. Manage your stress with the same seriousness as you manage your diet and exercise. Chronic psychological stress elevates cortisol over the long term, which drives visceral fat accumulation, increases inflammation, and raises blood pressure. I know that telling a woman in her 60s to manage her stress can feel almost laughable. There is often so much pulling at you from every direction. But even small, consistent stress reduction practices make a real physiological difference. Breathwork, time in nature, meaningful social connection, creative activity, contemplative practice, whatever works for you, the mechanism is real. Do not smoke. If you still do, stopping is the single most impactful cardiovascular change you can make, at any age. The benefit of cessation begins almost immediately and continues to compound over years. Now I want to give you a practical protocol, something concrete you can take from this video and act on this week. Step 1. Book a full cardiovascular blood panel if you have not had one in the last 12 months. Ask specifically for fasting lipid panel including LDL, HDL, and triglycerides, fasting glucose and HbA1c, high sensitivity C-reactive protein, and Lp(a) lipoprotein a. Write those down. Step 2. Measure your blood pressure at home, not just at the doctor's office. A good home blood pressure monitor is inexpensive and widely available. Take your blood pressure twice in the morning and twice in the evening for a week, sitting quietly for 5 minutes before each reading, and bring those numbers to your next appointment. Step 3. If you are within 10 years of your menopause and you have not had a proper conversation about hormone therapy, a conversation that includes your cardiovascular risk factors, your symptoms, your family history, and your personal values, seek that conversation out. Find a clinician who is well-versed in current menopause and cardiovascular research. You deserve an informed discussion, not a reflexive dismissal. Step 4. Commit to 30 minutes of brisk walking every day. Not as a vague intention, as a scheduled appointment with yourself. 5 days minimum, 7 is better. This single change, sustained over months and years, has measurable effects on blood pressure, lipid profiles, arterial elasticity, and overall cardiovascular mortality. Step 5. Add 2 resistance training sessions per week. Start with body weight if that is where you are. Squats, modified push-ups, resistance band rows. The goal is to progressively challenge your muscles. Your heart and your metabolic health depend on you having and maintaining muscle mass, and that requires active effort after menopause. Step 6. Prioritize sleep as a medical intervention. If night sweats or insomnia are chronically disrupting your sleep, bring this up with your doctor, specifically framed as a cardiovascular concern, not just a quality of life complaint. Step 7. At your next doctor's appointment, ask specifically about your 10-year cardiovascular risk score. This is a calculation based on your age, blood pressure, cholesterol levels, and other factors that estimates your probability of a cardiac event over the next decade. Knowing your score gives you and your doctor a concrete basis for decisions. The heart of the matter, if you will forgive the expression, is this. Menopause is a biological inflection point. The decades before it gave you a degree of cardiovascular protection you may not even have known you were carrying. The decades after it require you to be active, informed, and intentional in a way that simply was not necessary before. That is not a punishment. It is just the reality of how female physiology works. And the women who understand this reality are the women who are positioned to live long, healthy, vital lives well into their 80s and beyond. You are not powerless in this, far from it. Most heart disease in women is preventable. The research is consistent on that point. Lifestyle, metabolic management, appropriate medical support, and, in the right circumstances, hormone therapy can dramatically alter your cardiovascular trajectory. But you have to know what you are dealing with, and now you do. I will be here every week with more of the science that I think every woman over 60 deserves to understand about her own body. If today's video was useful to you, please share it with someone you care about. The woman sitting across from you at dinner who does not know her blood pressure is climbing. The friend who chalked off her fatigue as aging. The sister who has been putting off getting her cholesterol checked. Share this with her. Take care of that extraordinary heart of yours. It has worked hard for you and it deserves your attention.